So thanks everybody, and it's good to talk to you, and hopefully we'll all learn something from each other today. And so without further ado, perhaps we should talk about it. Now, I think I'm probably the newcomer, and we've only recently introduced FeNO into our CCG, and you mentioned hubs. We've actually got 9 machines that we're using on a hub and spoke model with hosting practices, those obviously who've got the machine, and non-hosting practices, those who are referring patients in for testing. And so far, fingers crossed, things seem to be going very well. How has it worked in your particular localities?
You were saying, weren't you, that you'd got a hub as well? So
yeah, so we have a hub, and then everyone gets referred into the hub. So we were trying to do ARTP level diagnostic spirometry and then supporting that with FeNO. We looked at doing that after we'd seen the NICE guidelines recommending FeNO as supporting asthma diagnosis, and the BTS talking about using FeNO around people who aren't treated yet. So we thought, okay, how does that work? How does it go? And we weren't sure, and we spoke to the hospital as well, and the consultants there had a very different way of using it to what we thought, but we didn't also know what we were going to do with it, and it's evolved over time quite a lot. So I guess one of the key things we found is it's enabled us to give people very individualised treatment. So it's been amazing to say to that person, this is your number, then follow that person up for 6 weeks later and say, this is now your new number, and they can see the effect of treatment as well as feel it. There's something about the number has given them that extra compliance. We've had a lot better asthma adherence to medication.
So that's good. So healthcare professionals are more confident,
right.
Patients are more confident, and the other way for me. So I work in a practice in primary care. So I'm not part of a hub, but I do have a FeNO machine. And one thing that I also find that's really useful to use. So for children, when you've got parents that are saying, I don't want them to go on steroids, no, definitely not. And actually, by doing the test, showing them a number that is high, explaining what that means, that is showing that there's inflammation in the airways that is likely to respond to inhaled corticosteroids, then people are much more open to actually letting their child give it a trial. And then what you can then come do is get them back. They do the test again, they can see that it started to come down, and also you can use it as, this doesn't mean your child is going to be on inhaled corticosteroids forever. What we're going to do is we're going to review them and monitor them. If the level stays normal and there's no symptoms over a period of time, we can look at reducing that. So I think that whole thing, people do love a number. Don't they? They really love a number, and it gives them confidence, gives healthcare.
We like the number. It's lovely when you see someone and the history sounds probably like asthma, but it's not 100%. The spirometry is on the borderline, and their FeNO comes back as 104, and you can go, okay, I'm pretty confident that the combination of all those things together is this, and knowing a FeNO of 104 means you'll probably respond very well to steroids, and then we can follow it up.
We found on our area that over many years we've tried to get people to have confidence to step down, and even all the guidelines and all the education we've put on, many people, including patients and some healthcare professionals, if it's not broken, let's not try and fix it, so you're not having any problems, your asthma's well controlled. Yes, I know the dose is probably double what I should be giving you, but let's not do anything about it, we'll review it in a year. And we found almost like an inertia to actually doing anything around these. And the other thing for me is that we looked at our admission data, and we find there are lots and lots of attendances from under 16-year-olds. Clearly something is going wrong, and we think that people are being treated according to national guidance, but clearly compliance and understanding of the condition, and as you say, not having a reference number is probably all contributing to that.
Yeah, I do, yeah. Like, I know we keep going on about the number, but I think it's right. It's things like, when you're looking at objective measurements, for example, if you did spirometry, then in more than half the people you do it, it's likely to be normal. On adolescents, even when they're symptomatic, it's likely to be normal. So actually what I think can happen if we're not making sure that healthcare professionals and patients alike are educated, you think, oh, well, they haven't got asthma then.
Yes.
Whereas if you've got something where, okay, that test is normal, which actually isn't unusual, but actually look at this test. Yes. So actually having that additional you know, this is saying, yes, your lung function is apparently normal, but this is saying, yes, there's inflammation in your airways, and if we don't manage this, then you're potentially going to run into trouble.
And it's finding that compromise between all the guidelines that say there's none of common sense clinical acumen around your symptoms, but then we need some tests to support that.
It's pieces of a puzzle.
Yeah.
Pieces that what you want to do is fill them up to get the end story, isn't it, and get that diagnosis. Is it your nurses that do the test?
So it's a combination, it's a multidisciplinary clinic. So there's a GP, we have a prescribing clinical pharmacist, and we have a nurse practitioner.
So any of them might be seeing patients and doing the test?
So any of them might be seeing patients. So I use the machine and do the test, the pharmacist uses it. We work out of the hub whenever it's appropriate.
Is that the same with yours?
Well, at the most, I do a sort of regular monthly presentation at our nurses forum, and they always like to bend my ear on things that they want me to do. And this came out of a nurse forum meeting. So at the moment, because they feel they've got this monopoly, and I think most of them do a good job, they've just said, we're conscious that, you know, you keep telling us our inhaled corticosteroids are off the scale and we need to be doing something. So give us the tools to do something different rather than, you know, proxy measures of asthma control tests, which is okay in its own rights, but adding another dimension into that improves the accuracy of the diagnosis and the management. And as I mentioned, we've got 9 of these machines now, and there's kind of envious eyes are looking at those practices with the machine from those that haven't actually secured one yet. But I kind of held out the promise of maybe to use a metaphor, jam tomorrow. If this works and we can demonstrate it, then obviously I'll be able to probably secure some more funding. It removes a lot of the uncertainty. That the message we got was, I don't think you need a higher dose, and that kind of introduces in the mind of the patient uncertainty. You're not really sure, are you? Well, no, perhaps, but then you say, well, I now know because of this test result that your inflammation is still present, it's not present, and therefore I can safely, and it's that confident message that comes over as a result of having this this that means the patient is not going to go and say, it doesn't seem so sure that I'll go up to A&E and see if they take a different view. And we do know that it's the confidence in the way the message is conveyed, which means that the likelihood of the patient or their parent or guardian accepting that message rather than introducing a note of doubt.
So is it GP, you're obviously really on board with this,
yes,
and you've got hub. Do you think that's the same for all of your profession, or do you?
I think it's not understood what the FeNO does as yet. So in our area, we've been trying to explain what things are, but running out of the hub, perhaps we're not sharing that as much. So that's something that definitely needs to be shared going forwards.
So do you think, are they going to go to practice and say, oh, I've heard of this test and so-and-so's got a FeNO of this number, and well, I want the test?
We feel that rightly it's a good clinical improvement in the way we practice medicine, and therefore everything we do along that lines, we're using social media and we're using the local media, and I went on the local radio station to promote this as a positive improvement in the way we manage patients with asthma. And we decided the people who put forward an expression of interest are the most interested in managing asthma. So early adopters, if you like. And so what we thought, we would evaluate the outcomes from this early adopters and then use that to disseminate into a slightly later adopters and the laggards at the end. The last thing we wanted is have this really good piece of equipment sat there in a box and people don't realise how to turn it on. They've all attended the training, but by the time they open the box and learn how to turn it on, the training needs to be repeated. So as always, we try and do the committed practices who are really up at the forefront, and then we take it from there. So this will probably run for, we think, probably a year, and then we will evaluate the benefits and get some qualitative data from practitioners and patients, and then use that as the basis of a further business case to extend the number of machines that we have.
I know from our point of view, we found that it's about individualising care very much so. So when we spoke to hospital consultants, they use it quite differently or don't use it in the same way, but in primary care it was very much about individualising that person's treatment. And it doesn't matter so much about exactly what the number is, it's about what that number is for them, which is what you're saying about knowing their number, and if they're having a bad time you can follow that up and go with it. And that's giving people back a bit of that control and power for themselves. That's what I like to think with asthma. Instead of us telling the patients, this is the inhaler, this is what you've got to take, we're very much about these are the options, this is what we're suggesting because of this, working with them on choosing the right inhaler at the right time, and then how to step it up and down, and then monitoring as kind of necessary. We've got some patients who sometimes feel that their asthma's more seasonal, and there's the idea that you can actually test them at different times of the year and see if there is seasonal inflammation is a really interesting
that's
idea,
individualising, isn't it?
Absolutely, and makes that person happy with those people who traditionally upped it in the summer to 2 puffs and dropped it in the winter, or vice versa. Actually, is there something that supports the way they're doing their inhaler? Does that keep their inflammation under control? And therefore, that's a reasonable thing for them and their symptoms.
When you asked for funding, did you kind of find a reluctance? Was this seen as like smoke and mirrors?
It was seen as something to try,
Yeah.
because we're looking at putting together this respiratory hub. So I'm lucky that where I work, the group of practice is very forward thinking and said, we have a problem with asthma prevalence. They have a high asthma prevalence for the population, and we should work together. So they used some of their practice kind of allocated money from the CCG to fund the project. So they're very forward thinking. They were thinking, right, we should be doing a respiratory hub, and then we were able to work with our pharmacy colleagues and other bits to put the team together.
I found that, yes, I had a very good, knowledgeable GP colleague who was also very passionate about this, but then had a lot of scepticism, that's probably, but slight degree of cynicism that is this just another test that, you're already fairly sure that what should be happening. How is this adding value, and how is this adding to the diagnostic certainty? How is this adding? So I had to try and convince a lot of non-medical people about the value of this, but unfortunately many of the non-medical people control the budgets. And so trying to give them enough knowledge to dispel any sort of, it's just a box of tricks. Well, it's not actually a box of tricks. And then trying to explain how it would work in practice, and having the hubs as kind of centres of excellence locally. And obviously at that time I didn't know about primary care networks, but now fortunately primary care networks seem to have taken a giant leap forward, and there's one, in some cases 2 of these machines in each PCN. So you could see that immediately people might be referring to colleagues within their PCN to make sure the testing is done. And so the patient takes their referral piece of paper, phones any one of the surgeries of their choice, and said, I've been given a piece of paper, I understand I can come in for a short test. Can you tell me when the next availability is? And if they say, well, it's Friday, but I do know that the practice 2 miles away can do them tomorrow, then we leave the patient. And so the number is given to the patient on a piece of paper. They take that back to the referrer, and that's integrated within the updated asthma consultation. So we do find it's working quite well. And the trick for us has to emphasise to the patient the value of this number.
I think it's been quite interesting for us seeing that sometimes patients have had a very high FeNO, over 100. It's come down very rapidly with steroids, but then actually their symptoms haven't improved very much. And that's enabled us to say, okay, so we need response variability. You had a really good response to the dose of steroids. Whereas as a GP without the number, I might have increased their steroids. We've gone, actually, that's not doing enough for your symptoms. We've looked at it and added in other things, allergy related, and actually their symptoms have improved significantly with that.
With the additional.
Additional, and where that one thing had been tried on its own, like antihistamines and things, and hadn't provided any benefit, the combination of the 2 has provided really good
But
benefit.
You're right, isn't it? Yeah, if you hadn't got the machine, you thought, well, they've come back, no, I'm not feeling any better.
Yes.
Right, let's up you again. And before you know it, they're on
absolutely
high dose inhaled corticosteroids, staying there because
That's
they're still
right.
symptomatic.
And if their numbers
But
stay
you've
low,
shown that's actually made a difference. Have you both noticed a big savings in sort of prescribing costs for inhaled corticosteroids?
Well, we track savings, and I think most people will know that your asthma is worse at certain times of the year, either summer or winter. So what we're trying to do is get a longer term picture, because if you don't compare apples with apples, you're going to get misleading information. We've done some work around changing inhalers to try and make them more simple. Still, lots of people we find can't use meso-dose inhalers, however many times we demonstrate them. Not everybody wants a spacer device, and although people think they can use them, we find often the technique is quite poor. What we've been measuring more carefully is the high dose inhaled corticosteroids, and what we want to see is a sort of the number of people maintained on very high dose, the milligram a day of fluticasone and equivalent in budesonide and beclometasone. We want to see that coming down. And we have, to avoid the system becoming swamped, as it were, we've set some criteria whereby they would be our priority patients, including frequent exacerbations, overuse of salbutamol, people who are on almost heroic doses of steroids, either oral or inhaled or both. And so those are our priority people, and therefore they're easier to track because we will have the intervention numbers of those. So what we're trying to do is get a cohort of about 300 or 400 people who are the most aggressively treated, and look for changes in that rather than looking at all the prevalence of our asthma patients.
Okay, in our hub we agreed it would be a qualitative piece of work, and we had agreement with the CCG that it wasn't around the funding, but actually the more we got into it, the more we realised actually there was a cost saving because of reduction in the steroid doses, because that being confident that the person had responded well to steroids, the level had come down to less than 20, so you were happy that the inflammation was in control along with their symptoms being in control, meant that we were confident, the patient was confident, and they were happy to halve the dose or lower the dose, and we lowered people's dose much quicker than I would have done in normal practice. If they've been stable, maybe they've been stable for 3 months, their FeNO remained less than 20. We halved the dose at that point, repeated it again a month or two later, and it's still low. And the patient still doesn't have symptoms. So actually that person, although they may have had a higher dose initially, has ended up within 6 months on a lower dose, which is what they need for their own maintenance, rather than being on a higher medium dose and then reviewing it at a year and maybe leaving it because it was controlled. So it's been a very different amount. So there's definitely been a reduction in spending on high dose steroids, and hopefully therefore a reduction in any harm from higher dose steroid.
How about yourself? I know you have your own machine that you
I do, yes.
Machine will travel, and I know you you sort of take this with you as a prized possession.
I do.
How does it work in your scenario?
Well, I've got sort of two different scenarios. Obviously, one is that I just take it to my clinic and I use it, on my patients. I use it to help support a diagnosis of asthma. So if I'm thinking somebody's got asthma, I can use the machine, and it's going to come up with a higher number, so I know that they're going to respond to inhaled corticosteroids. So obviously, if we're looking at sort of cost savings for the NHS, that person's going to less likely to have an exacerbation, less likely to end up in hospital, and obviously improve their quality of life. But again, this is just sort of single practice based rather than as part of a hub. Again, I've used it for those people that are saying, I don't want you to take me down. If you take me down, I'm going to have an attack. I've used it quite a lot with that as well. I've also used it for people, I think you already said, Keith, who are saying, yes, I do use my inhaled corticosteroids all the time, to sort of question what it is that they're saying. So certainly on a practice level, I'm sure there's been a lot of cost savings as well as patient benefit. And then the other time that it's used, like I said, is I travel the country doing education for people who are working in primary care. So it's actually getting the message out there, what it does, how it can support people. But I'm not always in front of the people that would be able to make the decision to buy one. So I think that is one of the problems. But I think it's raising awareness. A lot of people don't know about it, but when you tell them about it, they love it. So, it's something maybe somebody could have another conversation with somebody who does hold the purse and says, oh, well, I went on this training course and I saw this great machine.
We had a slightly different approach, so it's very valuable to hear what you've said. I engaged with one of the senior people from Circassia and said, I've got a lot of sceptical clinicians here, some of them very sceptical, some of them slightly less sceptical. How could we get some convincing data? And I got all sorts of work that had been done across the UK, and people said, yeah, but it's not us. And so the company kindly loaned us some machines that we could then put in situ in a couple of fairly big practices and say, okay, there it is, it's yours. We've got a GP or a nurse with some expertise in there. See what you can do with it. We've got several of these machines in place now, but I know that come 12, 18 months down the line, there'll be pressure to get some more in, because I have no doubts at all that the results that people will see will kind of fundamentally change the way we practice medicine around asthma management.
Yeah, we're at the point where we've kind of convinced the CCG, so we have a machine for each primary care network, but we haven't yet convinced the other 3 networks about what to do with it. But using our pharmacists to do that in those networks is probably the better, well, looking at how we go forward.
Do you envisage that the PCN pharmacist is going to be doing a lot of this work? Is that
well, it depends. It's finding someone with the right interest. So obviously the pharmacist we have has an interest in respiratory medicine, and she's great at what she does, and has really, we've all learnt so much with this. And what we've learnt is actually being part of that multidisciplinary team within the hub seems to work so well, and all understanding it and using it.
Do you think it's in 20 to 21 QOF, the FeNO has actually been mentioned as a test that could be done? Do you think that will increase the uptake of it in primary care?
I think it might do. We've already had a few practices who aren't in our hub approaching us and saying, so could we have this FeNO test? So I think the word is starting to spread with the idea, and it's really exciting to know what that word is and to kind of be there. But I know when I started, I didn't know, and I know the hospital use of it more about, well, it's just diagnostic, whereas our primary care is actually, no, it's so much more. It's so much about management, so much about personalised care. And
I take on board what you're saying, that it needs almost like a respiratory champion or champions to get this going. If everybody's still ambivalent about it, it doesn't get traction, but people who are trusted colleagues who can really promote this amongst their peers and their colleagues is, I think, key to success with this.
What are your thoughts around the sort of education and how people feel about using the FeNO machine?
Somebody once said education, and I think that's probably an understatement, in that whilst we recognise that some people have very specialist knowledge, too many people do not have enough management and knowledge around asthma, and I think we both have underdiagnosis and overdiagnosis. So to support this initiative, we put on a series of local education events, around the time we launched, but subsequent to that, to show how this can be further integrated within the clinical consultation. We're probably no different from many other CCGs in that if GPs don't actually manage that condition, and most don't, they send the practice nurses on the education days. And I think when we put on the local one, it was almost like 5 to 1 of nurses to GPs in attendance. So that in itself tells a story. Many GPs feel I either know enough or I don't need to know any more information about that. I disagree, because what we've said is that the practice who's performing the testing has to guarantee that the person performing the testing understands enough about this condition and could reasonably answer any questions and provide reassurance. So should Dr. Jones, we don't have a Dr. Jones, but should Dr. Jones phone the practice and say, can you just tell me about this number, that they could provide a concise explanation and how, in their view, that is useful during that consultation.
If you're talking about asthma, then you're going to be talking about the test that can support what we think. But what I think is really, really important is that people need to understand asthma. And if they understand asthma, then they can see why this machine works so well. If I just did education on that, it would mean nothing.
It's got to be within the context.
It's got to be
asthma,
within the context. And that is then what gets people excited.
I agree. To you as a GP, how do you perceive your knowledge compared to your colleagues, both nurses and fellow GPs?
I know certainly for myself, I've learnt so much over the last year that I didn't know before, and certainly I had no idea what FeNO was until a year ago. So it's been a massive learning curve, even though it appeared first of all in guidelines years ago, actually understanding fully what it was, what the implications were, rather than just, you see graphs and they say, oh, it's not useful for this, but actually they're not looking at the right thing, and it's all about untreated patients starting off with and looking at that patient. So I've learnt a lot. I've obviously had asthma myself for many years, and I also discovered I don't take my inhaler correctly. So I'm one of 9 out of 10 health professionals who do not take their inhaler correctly, but I do now. So I think education is really, really important, and I know Circassia is working with us to put on an education event to talk about the FeNO machine and asthma in our area, so we can look at that. But yeah, it's definitely been really interesting learning about FeNO, how it used, and then seeing it used in practice. It's been a really, really interesting year.
Well, it's been this meeting's been really interesting as well, actually, because like I said, because I work on my own, really, it's been really good to talk to people that are involved in hubs and the services that you've been setting up. So that's been really, really good. So thank you for that. I've really enjoyed
Yeah, no, it's been
talking
lovely
to you
meet
both.
you both.